Complication of diabetes. As you know, diabetes is a disease that affects almost every organ. And one of the predominant ways it affects different organs is by causing microvascular problems. So what is microvascular? When we talk about vascular, that means blood vessels. And blood vessels we typically define into macrovascular and microvascular. Macro meaning bigger blood vessels that's more than 2.5 to 3 millimeter in diameter, which is blood vessels in the heart, blood vessels in the brain, carotid arteries that feed the brain, and the bigger blood vessel. The way diabetes impacts body and circulation and all different organs is typically by causing microvascular, which means really small blood vessels at the capillary level. And when that happens, it can start causing compromise of different organs. So one of the top three things is eyes, because diabetes causes what we call retinopathy, which is #1 reason for blindness in the United States. And the way it does that is by something called non-proliferative, which is the early part of retinopathy, and then proliferative retinopathy. And I don't know, I think you guys were supposed to have an ophthalmologist very soon on the thing, so I'm sure they can go over in more detail. You guys ever had an ophthalmologist talk about this before on the DMP app? Okay, but I just want to make sure I'm still live. If I don't see any comments, I feel like I'm not live. So okay, perfect. So dysautonomia, definitely we're gonna talk about this. So we're talking about, again, hi Heather, how are you? So we're talking about diabetes and the microvascular complications. So microvascular meaning small blood vessels, the big one being retinopathy, which is the eye. Second one is kidneys, so that's the nephropathy. Diabetics always would get kidney problems by same factor that I'm going to talk about, that common pathophysiology mechanism that causes this problem to begin with. Third one is diabetes neuropathy, which is nerves, and nerve ending gets impacted by diabetes. Again, same mechanism of what we call vascular growth factors. So because diabetes is a condition where type 1 means your body doesn't form enough insulin, or type 2 meaning your body forms enough insulin, but it doesn't create, it creates resistance. So it doesn't allow the impact of insulin the way it should. So I think I mentioned that last time when I was here, that people who have diabetes, their pathophysiology is very similar to somebody who's starving, because your body is resisting insulin. So now you have sugar that stays in your bloodstream but cannot go from your bloodstream to your intracellular. All your vital organs would not get the blood sugar, which is the fuel, the energy we need. And that's why the sugar is high in the blood and low inside the cells. But every cell, every tissue, every organ in the body needs fuel. It needs energy to function. So when the sugar, the glucose can't go there, it starts utilizing fat. So it starts utilizing the unhealthy way of metabolism. And when that happens, you get secretion of a lot of bad chemicals. Because anytime you're using bad fuel instead of good fuel, you start having all these chemicals, and they are called free fatty acid. These chemicals will now go and cause a plethora of problem. One of them is vascular growth factors. So these are different growth factors that go at a capillary level and starts building this extra piece of tissue, which in turn will start causing some of the problems. So in the retina, in the eyes, it would cause formation of microaneurysm, which means the blood vessel will get this microaneurysm, meaning like enlargement of the blood vessel or outpouching. So this is a very, very microscopic level, but your blood vessels start getting enlarged. So that's the first change that happens, with more capillaries form, and these are not necessarily good thing. And eventually it would lead to lack of blood flow because of this excess. So that's when it goes from non-proliferative retinopathy to proliferative retinopathy. And this is why people with diabetes will end up having blindness, loss of vision. It's a major reason. So that's why it's very important that if somebody is diabetic, they would go and get checked for for their eyes, where an ophthalmologist will check the retina. They'll put a special camera and make sure the retina doesn't already have those changes which has started. And if the retina has those changes started, it's a sign that you really need better diabetes control. So that's number one microvascular complication. Number two, very important one, is nephropathy, which means the kidneys. So kidneys will also act in a couple of different ways. There are several mechanisms by which the nephropathy or the kidney problem happens, but they're all because of the microvascular, right? So the blood vessel, which are very small, once again, for those who just joined. Somebody asked, are seeing floaters in eyes due to diabetes? It could be. So diabetes has floaters in the eye is typically a vitreous problem, which means vitreous is the fluid outside the retina in the front. So if you look at the eyeball, there is retina is all the way in the back, which is the curtain, but in the front there is vitreous, and then in the vitreous there are small blood vessels. If they rupture, there's a little bit blood cells. You can see floaters in front of you. So that's one of the most common reasons for floaters. Vitreous problem can also be from diabetes. So are seeing floaters in the eyes due to diabetes? It's difficult to say 100% of the time for 100% of the patient, but there could be a correlation. I would strongly recommend somebody's diabetic to see an eye specialist. Okay, I'm not an eye specialist, but I know that it can cause every kind of, even cataract, which is a lens problem. So diabetes can affect every part of the eye, retina being the most serious and more common. I was originally talking about the next one, which is kidney, and you can get diabetic nephropathy. And the way diabetic nephropathy starts is job of the kidney. There is something called membrane in the kidney. So kidney is a filter. Job of the kidney is making sure that the protein, it doesn't leak. Kidneys are supposed to preserve protein from getting out of the body by protecting. Unfortunately, when people have diabetes, some of the small molecules of protein, what we call microalbumin, it starts leaking first. And the reason is that your glomerular membrane, which is a part of a membrane, gets that proliferation. So that's another major microvascular problem from diabetes. And once you start leaking protein and albumin, microalbumin in your urine, it's a big problem, because your kidney function will start deteriorating. You will start losing, protein from the bloodstream. You guys can hear me again? Sorry, I got lost for a second. I think the connection went away. We were talking about microvascular complications, and the last question I heard is, how soon after diagnosis should you see an eye specialist? So I think people should see eye specialist, really soon. I think if you're diabetic, you need to see the eye specialist once a year. Okay, that's the recommendation. That once a year you need to see the eye specialist, and then depending on the finding that somebody has, you can decide how quickly you wanna see them, how frequently you wanna see them. How soon after developing diabetes? I would say like within a year, I would go and see an eye specialist. It also depends if you have other risk factors. If you have hypertension, you have cholesterol, you have any, obviously if you're symptomatic, then immediately. If you're completely asymptomatic, you have perfect vision, you could wait a few years. But overall, the diabetes impact, the microvascular impact, happens with glycemic control. So if you're diabetic and have a poor glycemic index, you should definitely see Okay, I think I lost everyone. I'm right back. I think every time I'm getting a text message from someone, my phone is logging me out of this stream. Not sure. I hope people can hear me though, because I see a little human sign. So I think I have followers right now. Sorry, and I apologize for this thing. I don't know why every text message is kicking me out right now. So I think somebody asked a question. If you develop diabetes, how soon should you see an eye specialist? And the answer is, it depends on the other risk factor. If you have symptoms, see them right away. If you have hypertension, any vision problem, definitely see the ophthalmologist right away. If you're completely asymptomatic with perfect vision, even then, if your sugar control is not very good, you gotta see an eye specialist right away. If you are type 1 diabetic, and you just got diagnosed at a young age, maybe 4 or 5 years you can wait, and then you can see that, the recommendation is wait up to 5 years. If you're type 2 diabetic, that means you're a little bit older, more likely to be, in which case you gotta see an eye specialist pretty soon, within the first year of being diagnosed. Okay, so the next question, and then I would say once it's established, you gotta keep seeing the ophthalmologist like once a year. The second thing we talked about was nephropathy, which is issue with kidneys. Again, once you have diabetes, you gotta get your kidneys checked. The way to check kidney is actually by doing blood work, which will tell overall kidney function. But very important, I would say even more important in the early stages, is urine test. Checking urine for microalbumin, making sure that people are not losing protein or microalbumin, which is a very small molecule of protein, because that's the earliest change we see. And the reason it's important is because there are some incredible medications that we can, that somebody can be started, and those medications can protect people from getting kidney problems. Is everyone with me so far? Can somebody just type something? I'm not getting any typed messages, but I hope people can hear me loud and clear. The next problem I wanted to talk to you about is neuropathy, which is nerves. So diabetes, I hear that people can hear me now. Good. So nerve problem is obviously very common as well. It's the same exact vascular growth factors proliferation causing the nerve problem. And somebody early on asked a question of dysautonomia, which is basically your nerve balance gets a little bit off. So that question, before I answer that, before I go through nerves, somebody asked a question that how bad is stage 1 CKD, but nothing being done currently. Is that right? Yeah, stage 1 CKD means your kidney, it's an awareness that your kidneys are having some impact. The way we decide, CKD means chronic kidney disease, and it has from 1 through 6 stages. So first stage is when your kidney function goes like less than 10% is off. And the way we determine that is by blood work, something called GFR, which is a glomerular filtration rate that tells us what people's kidney function. Once your kidney function goes, you go into stage 1, that means it's just the beginning. There's no need to panic. All that means is make sure we take control. So that means better control of not only diabetes and blood sugar, but blood pressure. Okay, diabetes and hypertension together is 10 times worse than either one alone, because diabetes worsens the impact of hypertension and hypertension worsens the impact of diabetes. So, I always say in medicine 2 times 2 is not 4, it's 2 times 2 is 22. It's perfectly true for diabetes and hypertension. If you're diabetic, your risk is 2 times more than non-diabetics for kidney problems, heart problems, circulation problems, stroke, all that stuff. If you are hypertensive, your risk is 2 times more than non-hypertensive. But when you have a combination, your risk is not 4 times more, your risk goes 22 times more. So that's why everything augments. There is a multiplication relationship here. So again, kidneys very important. The third thing we were talking about was nerves. That diabetes will affect nerves and cause neuropathy. So this comes as a wide variety of symptoms. There are all kinds of nerves in the body, and diabetes affects all of those nerves. So what are the nerves in the body? There are motor nerves, which is your muscles. These nerves can determine the capacity of your movement. Those do get impacted, but later on. So when they get impacted, people do get a sense of weakness, fatigue, and all that stuff. Before the motor neuropathy comes in, first comes sensory neuropathy, which is way early on, way more common, and can lead to a lot of problems. So what is sensory neuropathy? Those are the nerves that can feel things and sensations. So the most important nerves for this is lower extremities. And this is why a lot of people who have developed these microvascular complications of diabetes will complain that they can't feel things. They feel like they're walking on clouds because the sensation is gone, and there is a level of numbness. They also feel like constant tingling sometimes. This becomes an important problem because oftentimes if people have this neuropathy and they get injured on your toes, they get a little injury, or sometimes there is a little area between the two toes which will have a small opening, or they try to cut their toenails and may not even realize and take some skin. Now remember, diabetics are also more prone to get infections. So any of these things happen and they get infection, if you have neuropathy, you're not going to feel that. So now this infection is going to persist. And then what happens is diabetics also sometimes get serious circulation problems. So blood is not going to the lower extremities enough. And this leads to the problem of non-healing wounds and non-healing ulcers, what we call DFU, which is diabetic foot ulcer. Once somebody develops diabetic foot ulcer, they have significantly higher risk of not only losing the toe or the entire foot or entire limb, but also not surviving. So we always talk about heart attack, which is when when your arteries in the heart shut down, people get heart attack, and that is a very bad result, right? And everyone understands. Whenever you say the word heart attack, it's very clear in people's mind that it's a major problem. It happens abruptly, and it can completely change the course of your life. It can either kill someone, or even if you survive, you can still have a very different life. So it's a very impactful event, heart attack. People don't realize there is an event called foot attack. When your feet, which should be getting blood flow, the arteries shut down, they don't feed, blood to that foot, and now in combination with neuropathy, in combination with infection, people can get wounds, non-healing ulcers, diabetic foot ulcers, they get gangrenes, and this leads to amputation. And this amputation is a downward spiral, because once people form these amputations, these things may not heal, which eventually leads to more problem for rest of the body. And we know that 25% of the people who end up with major amputation will not survive even. So that's why the foot attack goes very under-recognized, and it's important to know. And the reason I'm bringing this in this conversation about microvascular, because microvascular complication like neuropathy will eventually play a role in leading to this non-healing wounds, ulcers, creating the ulcers in the first place, leading to amputation, things like that. So that's why I think it is very important that when somebody has diabetes, you get perfect control of your blood sugar, glycemic control. In addition to that, you gotta make sure that your other risk factors are in control. So that's why blood pressure control has to be perfect. Normally we say that anyone over one over 130, we call it abnormal nowadays. We used to call it over 140. In diabetics, it's even more important. Okay, even if the blood pressure is 135 and somebody's diabetic, that's a problem. Okay, same way your cholesterol control is very important. So within cholesterol there is LDL and then there is HDL. LDL is the bad form of cholesterol, which is very important to control because that's the atherogenic cholesterol, which causes plaque formation all over, and especially in diabetes. So if you're diabetic, chances are you should also be on cholesterol medicine, because somebody's cholesterol of a certain level is acceptable if you're non-diabetic. For example, if somebody's LDL is 135, if my patient has 135 LDL and they don't have any diabetes, I would say you don't necessarily need to start the medications right away. You can try exercise, you can try changing the diet, you can, there are multiple other ways. When somebody develops, diabetes, and now the LDL is at the same exact number, you should be on cholesterol medication like statins, because now your risk is much higher, and you have a lot more to gain or a lot more to lose with the cholesterol number. So that's why that becomes very important. Okay, there are certain other medications like baby aspirin, which can work as a blood thinner, and these blood thinners can also end up helping prevent microvascular and any kind of vascular complications. So remember, microvascular were the eyes, kidneys, and nerves. In addition, there is a lot of macrovascular complications, and they're also not that uncommon. Microvascular is when the heart arteries get clogged up and blockages, leading to stents, bypass surgeries, heart attacks, all that stuff. Other macrovascular is blockages in the carotid that causes stroke. And then other macrovascular, obviously, as I said, is lower extremity blockages and things like that. So all those things, once you get those macrovascular, you should also be on blood thinners like baby aspirin. which has a protective role, because aspirin in a very low dose and a baby dose works as a blood thinner. So it's a blood thinning medication that protects people from getting heart attack, stroke, and in diabetics it's very important to pay attention to that. So in nutshell, once you have diabetes for several number of years, you gotta start seeing you gotta start seeing diabetic specialists. There's a lot of plethora of incredible medications, which has amazing role. So if you are type 2, I think chances are you would start with metformin or glucophage, and then if that doesn't get it under control, or if somebody has side effects, there's a whole slew of newer medications which were not even available 5 or 10 years ago. There is two particular class of medication, GLP-1, which is very common and popular and has amazing benefits, not just for the diabetes, but it has benefits on other organs. And then there is SGLT2 inhibitors, which is also a latest medication for Farxiga and Jardiance, are the brand names. Those also have a lot of benefits in cardiac patients. So I'm a cardiologist and vascular specialist, so our patients benefit from some of these newer medications. So and obviously the insulin therapy itself has significantly improved as well. Insulin also now comes not only in injectable form. We have inhaled insulin that can be used. The GLP-1 right now is only injectable form, but they just approved another one, which is an oral pill that you can take. So again, I'm not here to promote any particular drug or any other company or anything like that. I have no conflict of interest, but the point I'm trying to make is we are so advanced now when it comes to diabetes management compared to 8 or 10 years ago, that it's a shame if somebody's glycemic control is still not well maintained, because we have a lot more tools in our capacity. Even monitoring, as you guys are aware, monitoring has become much easier. You have apps. You can just put a patch that can do constant blood sugar monitoring. Apple, I think, is coming up with a blood sugar monitoring app as well. So we have better ways of measuring and knowing where the sugars are, and we have a better way of controlling the blood sugar. What we really need to do now is to have a better understanding of why it is so important to get and so once we have that mindset and better understanding, we can really get amazing control. So does anyone have any other questions or comments on the stuff? I want to make it a little bit more interactive. You guys can hear me okay? I'm always worried that I froze and last 20 minutes nobody can hear me. Is any of you guys, is Danielle still there? Okay, thanks Dave. Thanks for letting me know. Perfect. Okay, awesome. Anyone has any particular questions I can answer? So does people have clear understanding of dysautonomia? Does it mean I should run at a higher blood pressure? So dysautonomia means, so we were talking about nerves, and I think I was talking about motor nerves, sensory nerves, and the third group of nerves are called autonomic nerves. So what are autonomic nerves? Autonomic nerves are nerves that control your vital organs in a way, right? So remember, heart at the end of the day is a muscle. And just like any other muscle, nerves control the muscle. So the nerves that control the heart are called autonomic nerves. Same way, your blood vessels are also muscles. There is a muscular component. That's why blood vessels can stretch, relax, elastic, stiff. And the nerves that control the blood vessels are also called autonomic nerves. Within autonomic nerves, there are the sympathetic and parasympathetic nerves, right? What it means is there are two set of nerves. One set of nerves, the role is to raise the blood pressure and raise the heart rate at an appropriate time. The other set of nerve does the opposite. And this is why and how our bodies are built, because this is the flight or fright response, what we call it, right? So when when we were built, we are a very old software, right? Humans are very old software. We are built to live in wilderness. And when a tiger would come to attack an ancient man, this is when your sympathetic nerve would kick in, which is your fight or flight, right? So which means either fight the tiger or run away. Either ways, whatever threat it was, you need, when you are trying to run away, you want the blood to move very fast, so you can really go fast. You don't have to think. So these are the sympathetic nerves which raises the blood pressure and heart rate. And then when you get wounded, let's say somebody cut somebody, people were in wars back in the days, or get attacked by an animal, you start bleeding. And when you start bleeding, your body's natural response is slow down the heart rate and slow down the blood pressure, so you lose less blood. So that's why these sympathetic nerves, which raises the blood pressure and heart rate, and parasympathetic nerves that lowers the blood pressure and lower the heart rate, we all have them. And at the end of the day, our blood pressure control and heart rate control is the balance between these two set of nerves, right? So in other words, anytime anything raises our blood pressure or heart rate, there is a set of nerves that will keep it in control, or it goes lower, set of nerves that will keep in control. So that's the autonomic function. Dysautonomia means that this function gets a little bit disrupted, and diabetes, unfortunately, is one of those factors that it can affect those. Like any other nerves, it will affect the autonomic nerves. In some people, it will cause autonomic dysfunction, or the other word is dysautonomia, which means that the nerves that can keep blood pressure and heart rate in control are a little bit off. So when people can be, their blood pressure drops for whatever reason, the defense doesn't kick in very fast. So they can feel very dizzy very quickly. And usually it passes away. Most of the time it's a very benign thing. It's not like those nerves are not working. It just come a microsecond delay, which can feel very scary, because you feel like off you go, you're gonna pass out. One of the strategy to help with autonomic dysfunction is allowing the blood pressure to run a little bit higher, but it's not. There could be multiple other factors, so I can't advise on a one-on-one basis. In general, when people have autonomic dysfunction, there are certain strategies, and I think you should certainly see an expert, several experts. You need to see diabetic experts like an endocrinologist to get blood sugar control perfect, so the problem stops happening. There are certain nerve medication. In some people, they make a little bit difference in them, medication that reduce neuropathy. And then finally, the blood pressure medication or not, the adjustment of it. And that's a careful titration protocol. You need an expert who can check your blood pressure, make sure it goes up, goes down, on those things, and then set up the goal, right? What is the goal? Goal is to not feel dizzy ever, or the goal is to protect the ill effect of hypertension. And you choose the goal. And in my patient, most of the time, I would encourage them to choose the earlier goal, which is, even if you are a little bit dizzy, as long as it's not pathological, as long as you can still live a pretty decent, healthy life, try to get blood pressure as nicely controlled as possible. There might be a point where, the nerves are so there's so much autonomic dysfunction that there is no other way but allowing the blood pressure to run a little bit high, in which case, make sure your kidneys are okay. Make sure you're getting other testing to make sure there are no ill effects of hypertension and diabetes on the rest of the body. Okay, but I think that would be my answer. My absolute pleasure. Anyone with any other questions, comments I can answer? So once again, I want to summarize. We talked about microvascular and macrovascular. Microvascular is eyes. There is proliferative retinopathy and non-proliferative retinopathy. Pick it up as early as possible. Any symptoms, absolutely get checked. Any otherwise routine exam. Also, if you're type 1 diabetes and young and otherwise no problem, you can wait a few years. If you're type 2 diabetic and a little bit older and have hypertension and some other risk factors, or have any symptoms, definitely see an eye specialist right away. Once you establish care, see them more frequently. Same thing for kidneys. Make sure you get your kidneys checked, because you get this microalbuminuria and loose protein, so get your urine test done. There are medications once you have this microalbuminuria which can reverse the damage. This is one of those things that we have a tool in our hand where we can reverse the microalbuminuria and reverse the nephropathy. So somebody asked me about CKD stage 1. That can be done as well. And the third thing, obviously, we talked about is the neuropathy. Within neuropathy, there was motor, sensory, and autonomic, 3 set of nerves. and diabetes potentially can impact all of them. So those were the microvascular complication. Macrovascular was the heart, stroke, lower extremities, preventing amputation, all that stuff. And finally, couple of simple strategies: get amazing glycemic control. So have that awareness that this is very important for a number of reasons that we talked. We have incredible apps to monitor and incredible therapies, including the newer medications we talked about, and newer insulin and all that stuff. In addition to blood sugar control, equally or probably more important is making sure other risk factors are perfectly in control: blood pressure control, cholesterol control, exercising regularly, and of course, goes without saying, if somebody has diabetes and they're smoking, that to me is a suicide mission. So really, it's one of the worst combination when it comes to cardiovascular health. So we really strongly urge. Again, smoking cessation has incredible new tools and techniques to help with that. So that to me is in a nutshell what we should do about the microvascular. Thank you so much for listening. Please do let me know if anyone has any other last questions. Jen, thank you so much for your comments. Okay, great. I think there were some technical errors in the beginning, but I think we got most of it sorted out later on. Again, thank you for having me, and please feel free to ask any questions, comments. Our website should be mentioned somewhere. It's apexheartandvascular.com. So it's www.apexheartandvascular.com. Feel free to ask any questions, comments. We are available for any questions. We are also doing telehealth nowadays. So even if you are not in New York or New Jersey, anything we can do to help or support. Okay, thank you so much, guys. I'm gonna go offline. I really appreciate it.